The Patient and Community Engagement Research, also known as the PACER program at the University of Calgary, is working to transform the role of patients in health research, planning, and policy. PACERs are individuals with lived experience of a health condition and navigating the healthcare system, trained in patient-engaged health research, who are creating a new collective voice by patients, for patients, and with patients. How is this achieved, and why is this important to affect system change? This is episode 14 of Pep Talks, the Patient Engagement Podcast. In this episode, recorded in the summer of 2020, we speak to Jean Miller, who is a graduate of the first Patient and Community Engagement Research Cohort. Paul Ferry first asked Jean how she originally got involved in patient-engaged research.
Well, it was 7 or 8 years ago now that a Canadian research body, it wasn't CIHR, I think it was called something different at that time, but a Canadian research body funded the University of Calgary and Alberta Health Services through Dr. Marlette, Dr. Marshall, Tracy Waslick, and others in the Faculty of Medicine, Cummings School of Medicine, to offer a program to patients to see if patients could be taught a particular set of research skills, and that those research skills engage other patients to bring a collective patient voice to system change. And that was quite successful. I'll tell you a little bit about what we did in that as an orientation as well, but that was quite successful. And now for the past 7 years, a number of us who have completed the program have been doing engaging other patients in research and bringing that voice to system change. So it was quite successful that way and continues to be. So my neighbor, who is my colleague, she had signed up for taking the program, and she said, "You want to do that too?" And I said, "No, I don't think so. I could. I'm a nurse by background. I have a PhD in nursing, and so research had a certain meaning to me. Not that we were both have post-secondary education, but that whole idea. No, I don't really know about that. But anyway, she needed some patients in her student research, so I went to the first one and got hooked and haven't left.
Okay.
So in that first one, the health system and the University of Calgary really wanted us to focus. First of all, the grant was for osteoarthritis research. They wanted to know how long is it acceptable for patients to wait for joint replacement surgery.
Okay.
And because we were patient-directed research, which is what PACER is, we said, that's not really the biggest issue. We know the system will do the best they can. We expect them to do the best they can to get us there reasonably quickly. Really, our issue is, how do we manage living with osteoarthritis? And we found, and so we said, no, we're not going to look at wait times. As our student project, we are one of our small groups in the larger project said we want to look at the experience of waiting for help with osteoarthritis. In our healthcare system, the only really expert we reach really through the healthcare system is an orthopedic surgeon. And we lived many, many years before that with our osteoarthritis. And there's very little in the healthcare system that supports us in that. We tend to have, we do have an illness system rather than a health system in many ways. And some of us are privileged enough to be able to afford to go to physiotherapy and, seek those other resources, which we do. But we really need the health system to understand what it's like living with this, waiting for surgery, or perhaps if we live with it, and improve what we do, we might not have to have surgery. So that was the study we undertook, and we found, had some specific findings related to that we needed access to expertise to address the problem I just mentioned. We need people to work with us as we self-manage. So really Sylvia and I in doing our research has really focused on osteoarthritis and how can the system help us self-manage. We spend very little of our lives in contact with the formal healthcare system when it comes to osteoarthritis, as I've already said. And it's really ours to manage. And we need help from the system to do that. Subsequent to doing our, I'm going to just come back though. I think I'm going to talk a little bit about PACER, because sure, I don't think you've had, yeah. So the Patient and Community Engagement Research Program, we do research for patients, with patients, but probably most notably, it's by patients. So patient participation in research, patient-oriented research. I've always thought, a bit of a digression, but I think an important point, that sure, yes. As a professional, as a nurse, I always did care and research oriented to patients. What else would I be doing? Yeah. And so in some ways, I have always found that perspective a little bit limiting, because it's basically professionals being oriented to patients. This takes it a step further. It says patients educated in research then engage other patients and bring that collective voice to the big R researchers and health system change. What we do is not big R research. We do not come out of this program hanging a shingle that we're a researcher. We work under the PACER program in a specific set of research activities and skills, with support from the PACER program and academic oversight, to bring that collective voice. So it's different than professionals engaging patients in research, because actually, as I gave you in my first example, it comes down to what is it that patients think is important. So that's the key of the PACER process. And as I told you about our student project, which did turn around into that. So my colleague Sylvia and I have worked with the academic researchers in bone and joint health. I was on the bone and joint SCN for 6 years, and bringing the patient voice. And we've done, I think, about 6 studies in that regard. We've also done others related to other topics, but our focus is how bringing the collective patient voice to system change so that people living with osteoarthritis can manage their osteoarthritis well. So we've done a number of projects that way, and they have really been, in those projects, fully embraced by the research teams. They've been wonderful people to work with. They engage us right at the beginning, before they put their research project together. Right at the beginning, they bring the patients in, and then we continue through until dissemination. And we contribute our part to the articles that they produce. In bringing, listening to patients right at the beginning, just to strengthen the point about what is the patient voice, what is the patient concern. One project was going to start out by developing an app for family doctors to use to monitor patients with OA and their progress toward the potential of needing surgery. And through research with the researchers at U of C and U of A, with family physicians and patients, it turned around to being, family doctors really weren't interested in that. They didn't think they would use that, but patients said they would use it. So we've had at least 2 stages. This a couple of years ago now, so I'm not going to remember all the details, but basically the project turned around to one to be developing an app right from the beginning with patients, family doctors, and patient researchers to help people with OA self-assess and manage their OA. So that's another example of how things turned around. Our research has also had an impact on how the system is changing. Dr. Deborah Marshall and her team have done work on a central intake model for osteoarthritis in Alberta, and through our pieces of the research, we do a little bit. We do our PACER piece within their bigger projects. The recommendations that have come from patients have been directly integrated into the matrix or parameters of that kind of a system. So Sylvia and I have been involved for quite a few years, and sometimes people will say, well, is it making a difference? And we wouldn't have stuck it with it this long if we didn't see it making a difference. It definitely has.
So earlier you talked a little bit about your background with a PhD in nursing. Do you want to talk about maybe how that might have informed your work in patient-oriented research?
Yeah. Well, my background as well as a PhD in nursing is nursing education.
Okay.
So that whole education piece kind of underlines it, I guess. What the PhD in nursing did for me was to understand the big R research, to see how patient engagement research of the type that PACER does fits into the broader picture. And it brings a different kind of voice than a voice gathered by researchers. And then I also, because I've been involved in nursing education and the healthcare system, bit from the sidelines, but over my long life in nursing, I had a fair amount of comfort in terms of interacting with people and working in that fashion. So that was very helpful. But beyond that, I needed to put that aside. I'm not doing nursing research. I had to think about it as something from the patient perspective, rather than from the outside objective professional perspective. I think for me, some of that was comfortable, because in the beginning of my nursing career, I worked for the Victorian Order of Nurses.
Okay.
And did nursing care in people's homes. I did my degree in nursing at U of S, and then came to Calgary when my husband and I were married, and worked for the VON. In that environment, you're in people's homes. You're invited into their homes, and you are invited to their table to help them with their health issues. And so for me, I think that I'm beginning to realize these days, especially the things that are happening these days, that that patient voice right at the beginning in the bedside, and the dominant voice in my life as a nurse, was the patient. And I kind of think that's helped me in terms of stepping away from academic, professional-led, discipline development research. I think the discipline developing the disciplines and what nurses do, when they do it, how they do it, we need that. It's extremely important, but this brings a different piece to it.
So what would you say excites you most about patient-oriented research and patient engagement?
I've often said, who would ever have thought 10 years ago, 15, 20 years ago, who would ever have thought that patients engaging other patients would actually have an impact on what the system does? Who would ever have thought that people who aren't researchers by background could get the skills they need and be supported by a program like PACER to bring that voice and actually see change? That's what excites me about it the most.
I think that's what excites lots of people too. Yeah. So I always like to ask people for advice. So if you could give advice to researchers who are maybe thinking of working with patient partners, but they haven't done it before. Is there any advice that you would give them?
Yes. First of all, involve patients right at the beginning as your ideas start to form. I've been in audiences and groups where they'll say, well, the researchers and system just going to get together and kind of figure this problem out, and then we're going to invite patients. From my experience and what I've learned from what I do, the value is in asking patients first to become your partners. Some of this is based on the fact that both Sylvia and I have participated in CIHR SPORE grant reviews, where the emphasis is on patient engagement. And I would say that I was astounded the first time I participated in that, where the voice of the researchers and the voice of the patients were equally important in terms of getting funding. And sometimes the researchers would step back and say, yes, even if the research model isn't as strong as it should be, we should do that. Or patients would step back and say, well, patient engagement's kind of light here, but this is an important thing. The collaboration is amazing. And I think it's important that people who are embarking on research know that. I think the other thing is, don't be afraid of patients. No, fear isn't the right word, but don't underestimate what patients can bring to because we come from very diverse backgrounds. We'll hear, well, patients aren't comfortable with using, say, Zoom or the computer, or we got that in relation to that. Family doctors worrying they're going to have to teach patients how to use the app. The patients we interviewed were all older people, and they didn't have problems with that.
Yeah.
So there's the need not underestimate, and the need, although I know in research ethics, the whole balancing thing of people who might be at risk, and putting patients at risk in research is extremely important. Don't go too far in that and say, well, then therefore we don't want to put them in that position. Another thing I would say is in our student research, and most of the research Sylvia and I have done, we have gotten the voice of lots of patients, collectively voice of lots of patients, but they tend to be patients like us, of a certain age, a certain socioeconomic status, a certain education level, more like us. In our student project, one of our fellow students had direct experience with living on the street, and she was able to bring to us a person who did live on the street with osteoarthritis. And when we gave our report and published our article on that, we made it very clear that this one voice represents way more than our small, rather homogeneous collective voice offers. I don't have any easy answer to how you engage people more broadly. I think with PACER now becoming closer with Alberta SPORE, I think there might be some opportunities there. But I would say that's really something that people need to consider in their research. That's probably the main things.
Oh, yeah, for sure, yeah. What about that's sort of the maybe the flip side do you have any advice for people who might be interested in getting involved as patient partners or patient research partners or patient advisors for the first time?
Take advantage of whatever you can in terms of education. I mean, there's a PACER program, but there's the education through SPORE, and whatever opportunities you can in terms of how to do that. Alberta Health Services has a patient advisory group that is province-wide. I would suggest people get involved in that. Never underestimate the value of your voice. You're not there to complain. You're there to help with the solution. And the system, especially when it comes to managing illness in the community, which is frankly where most of us with chronic illnesses, the biggest piece is there. Don't underestimate what you have to offer. when I did it, I teamed up with my colleague and neighbor Sylvia, and to do it as a team worked really well, because we are at a stage in our lives where between the two of us, we're sort of like one. Between the two of us, we can do this, but also to meet other patients who are involved, not necessarily with the same kind of health care issues you might face, to hear what they are doing. I think there's a lot to be learned collectively.
Mm-hmm. Is there anything else you wanted to talk about before we go today?
Yes, there is. I was presented at a conference in Banff a few years ago, and before the presentation before me was talking about some kind of a assistive device or something for people who are diabetics, something that was going to help people with their diabetes, and then they found that once they got all that research done, the healthcare providers at the bedside weren't all that keen on it, and the patients weren't either. I was really young in my experience with patient engagement and research. And as I look back, I should have asked the question, did you ask the patients first? I think and who do you get the knowledge out to? We know how long it takes to get academic knowledge, the publisher perish, and those are important things in terms of academic process and progress. But I have said in more than one place, and I'll say it here, why don't you get it to the patients first? So at one time in some of our focus groups with patients, I learned about braces for people with knee OA, which is my issue. And so I thought, I'm going to try one of those. I had no idea. I looked it up, knee braces. I couldn't really find anything, but it sounded like a good idea. My point there is, if you get the information to patients as you're finishing your research, we're the ones that are most affected by it. We will use it. I know the whole issue of best practices. I know all about that coming from nursing research, and I wouldn't discount that for a minute. But sometimes, how perfect does it have to be before you would tell patients about it? I think that if knowledge can be brought to the patients more quickly, and through some kind of a system, a support system for people, for example, with OA, in helping self-manage, they have the opportunity to follow up with their health professionals to see what is really best for them to try and how they might do it, and have that equal discussion about what they're going to do, because basically they're going to do what they're going to do when they leave you as the health professional. I think we could really have an impact on getting knowledge used by the people who need to be benefiting from it.
Any big ideas for how to do that?
Well, one of them is not to have to wait through the academic research process to get things published and disseminated, because it has to do with expectations of grants. And I think granting people need to say, and how are you going to get this information out to patients? You're going to do your academic publications, but please provide us with information on how you're going to get this information out to patients in a timely manner, and what things do you need to consider to do that. I think the granting in the academic process, although most of my life was in post-secondary education, sometimes can get in the way of that.
Oh yeah.
And there are lots of, I'll use the word social media, but I don't want to use it too loosely. There are lots of ways to get information out to people these days through very credible organizations. Alberta Bone and Joint, for example, at McCaig at U of C, lots of, and through the SCNs and through Alberta Health Services, the Alberta Health Service website, where there's lots of information for patients on OA. those are the processes that need to be used more.
Thanks so much for joining us on the podcast today.
You're welcome. Thank you. I enjoyed the time.
Thanks so much for joining us for this episode of Pep Talks, the Patient Engagement Podcast, brought to you by the Alberta Strategy for Patient-Oriented Research Patient Engagement Team. Special thanks to Paul Ferry, Sadi Ahmed, and Sandra Zielinski, and our summer students Sarah, Sydney, and Stella for their co-production. Make sure to subscribe to this podcast wherever you found it, and we hope you'll join us again for more interesting discussions about patient engagement in health research and healthcare.